Good morning, everyone. We are getting ready to get started on our webinar with Al Bishop. Just a few housekeeping items. If you have any questions, feel free to type them in the chat box, and we will answer them as they come in. After the webinar, you will receive an email with a link to a survey that we ask that you complete. And then it will also have a link to our help desk, which will have all the documents from the webinar that you can refer to. And certificates will be mailed out soon after in the next few days. We have some staff that are out sick, so as soon as we can get those out to you, we will. But again, if you have any questions at all as we are going through, type them in the chat box, and we will get Al to take a break every once in a while so we can get those answered for you. But Al, whenever you are ready.
I believe I'm ready.
Okay.
Fantastic. So good to have everybody here again on this wonderful Tuesday morning. Let's get started from where we have. If we do have any questions, please do ask our questions in the chat box, and then we'll try to answer those for you. And so yesterday we stopped with a little bit of data about HIV, AIDS, syphilis, chlamydia and gonorrhea, and then we were getting started here with the types of prevention that we can offer. So there's different ways that we can approach HIV and AIDS prevention. One of those is prevention through discussions about sexual activity. And the only way, as we start off the discussion this morning, the only way that we're going to know how to prevent HIV transmission through sexual activity, we have to understand what our constituents, our clients, the people that we're working with, understand what those terms, the phrases that they're using for different types of sexual activity. If we don't understand that, then we've lost the ability to be able to give them the appropriate dialogue and exchange. So if we don't understand what the new terminology is, if we are maybe an old fogey or using terminology that's out of date, we might want to consider getting the updated information about that, because if we don't understand that, we definitely can't have that conversation. So if we were in one of those 6-hour classes that we have for 6 hours worth of training, we would get the opportunity to talk about those in more detail. But if you're interested in that, just let us know, and then we can give you more information. But talk to your colleagues, your friends, talk to the youth that you're working with. They can give you all kind of information that you never even dreamed of, that they would even know. I got a lot of the education that I got from actually talking with my clients. I said, what is that? What exactly does that mean? And ask that question. So as we're moving forward this morning, abstinence, simply not having sex. I mean, that's a very good way to not transmit HIV or get HIV transmitted to you or the individual. So how realistic is that? Well, I believe it's very realistic. But at the same time, everybody's not going to choose abstinence. So we need to know that abstinence is not for everybody. It's not going to work for everybody, even if it is the best method. So we need to talk about what abstinence is, again, not having sex in any way, shape, or form. But and more so, if abstinence would be the choice, then there's other factors that you want to make sure that they're aware of as how it can be transmitted, and again, through the exchange of bodily fluids. So the next best way is, if you're going to have sex and you can't guarantee that abstinence is going to be on the table, then protected sex will be the next best option to prevent HIV transmission. And simply put, protected sex is the use of a barrier method, a male condom, female condom, dental dams, anything that puts a barrier between the body fluids of each individual. The body fluids can and may have the virus in it, and with that, we need to make sure that if we're trying to have sexual intercourse of any type, sexual activity of any type, we need to make sure that if there's a barrier there, that greatly reduces the chances of HIV being transmitted from one individual to another. Another one is PrEP. And I don't know how many of you have heard about PrEP, or pre-exposure prophylaxis. you may have heard of post-exposure prophylaxis, meaning after someone gets exposed, what do? We talked about it briefly yesterday. When someone, a healthcare worker, is giving an injection to someone and then accidentally sticks themselves after they have given the injection to the patient or the client, they stick themselves. That's post-exposure prophylaxis. It's after the event has happened. We decide to do some testing and treatment, and usually that involves 2 to 3 days, maybe even longer, of medications to help reduce the chance of HIV getting a foothold in the body. Well, pre-exposure prophylaxis is completely opposite. It's giving medications to individuals who have willingly admitted that they are putting themselves at risk. Maybe they're not using barrier methods by using condoms or dental dams or female condoms of any way, shape, or form, and they're putting themselves out there, and they may engage in high-risk behaviors that put them at greater risk. So they can take medications, and these medications is an HIV medication drug. Right now, it's Truvada is one of the drugs that they use. Instead of being a multi-drug cocktail, meaning that using more than one type of drug, they use that simply that one drug. And it's my understanding, and what I've read and studied over the years, that it is quite effective by itself. And it's not the cure-all pill. It's not the invisible force field that's going to keep out HIV forever. But it does greatly reduce the risk of individuals being exposed, who are exposed to HIV and AIDS or HIV, of contracting it and it taking hold in the body. You don't necessarily have to take it every day, but just like taking any other medication, the more frequent and more you maintain your regimen and stay on the regimen, the greater the effects and the greater the protection that a person has. In the healthcare arena, especially in HIV and AIDS, we still recommend that if you're engaging in high-risk activities, to continue using barrier methods, male condoms, female condoms, dental dams, in addition to the pre-exposure prophylaxis, the medications, and it greatly it helps one another together. It makes the combined efforts better at preventing HIV transmission. And but that's been a major step forward in preventing HIV transmission. Again, it's not 100%, but it is wonderful to know that we have some options out there. Unfortunately, the downside to it is people think that now that we have pre-exposure prophylaxis, I don't have to be careful. I can just do anything that I want to, and that is not the case, and that is not the message that is being sent. However, that's what it's like they consider that a miracle drug, and they think we don't know what the long-term effects of pre-exposure prophylaxis is on the human body right now. For those that don't have HIV, we do know that if people take medications that are already exposed to HIV and have HIV in their body, that if they get on the medication, get off and get on, get off, get on, get off, start and stop, then it does cause resistance. So we don't know what that's going to be in the long term. Now,
Al, I have a question.
Yes.
I'm sorry. Someone was asking how the dental dams work.
How what now?
The dental dams. They were asking specifics on how they work. Miss Nuda Verma, I believe is how you say your name.
I'm not understanding the question. How does what work?
The dental dam. The question was
the dental dams. Oh, yes.
Mm-hmm.
Dental dams. We could look this up. I don't have any pictures of it, but dental dam is nothing more than a square piece of latex. It could be round, but it's a piece of latex that is laid on the body part that someone wants to perform oral sex with. And the barrier is usually latex. You can get non-latex ones. They do make both latex and non-latex. But that barrier device, that piece of latex or that piece of, and it's the ones that we used to give out are about maybe 6 inches wide and maybe 8 to 10 inches tall. and you lay that over the body part that you want to perform oral sex on. And while you can have the feeling and the sensation, it just prevents the individual from ingesting the other individual's bodily fluids. Does that help?
I'm waiting for them to see if they respond, if that answers their question.
Sure.
I assume it does. So we'll continue.
Fantastic.
Thank you.
Thank you for the question. I want to make sure that we can answer those questions for you. And let's give us any more questions that you have, and I'll do my best to answer those questions for you. So, moving forward, viral suppression. We're talking more about viral suppression. What is viral suppression? Viral suppression, again, we're talking about the virus. And by the term itself, suppression means to hold down, to keep down, or to hold back. So viral suppression means keeping the virus at the lowest numbers that we can possibly do. If we keep the virus suppressed in the body, meaning that we keep the numbers down, it does less damage to the body. Not only that, it has been scientifically proven that if you are considered virally suppressed, meaning that your viral count is almost zero or zero. It says here is less than 200 copies. We've actually got tests that can test less than 50 copies, and probably even greater than that. If you are virally suppressed, scientifically, medically, and clinically, then the chances of a person who is virally suppressed passing on HIV is almost impossible. I'm not going to use the word impossible. That's one of those things that as an educator and a health educator, that I don't like to use, because anything is possible. Well, it may not be probable, but scientists have shared with us that it makes it almost impossible for you to pass on the virus, but it definitely greatly reduces the risk of someone contracting HIV if they're exposed to their blood and body fluids to a person who is virally suppressed. So the ultimate goal here for somebody that is infected with HIV is, number one, if we can cure them. That would be the ultimate goal. Right now, we don't have that in 100%. We have that one case that we know for sure that person, Tim Brown, was essentially cured. We don't know what the long-term effects are, but essentially he's cured. And the others that were essentially cured have reverted back, and they have since then become positive, or HIV has been found in their bloodstream. So that would be the best possible case if we could eradicate HIV from the system. The next best scenario, since we don't know that there's a cure for HIV at this point, we haven't found that, is if we can keep a person virally suppressed. So not only are they less contagious, almost not impossible to get, but virtually impossible for someone to pass on HIV. It greatly reduces the risk for them to have that. But it also means that person is more healthy. The virus is not doing damage to their immune system. The virus is not doing damage to their internal organs. And that person is going to live healthier, going to have less sickness and illnesses as a result. And so their ultimate goal is, once we find that person that's HIV positive, get him into treatment, get him into care, get him on medications, and finally and ultimately is to get them virally suppressed. So when we find somebody that's virally suppressed, we find that there's going to be a healthier individual. They can function better at home and society, and if they do engage in activities, they may share bodily fluids, and they're less likely to pass on the virus. And so not only is the individual healthier, but it also helps our communities to be healthier. And so it's a win-win for everybody. So the ultimate goal is to make sure that people are virally suppressed to the best of our ability. But we can't do that if people are not coming into care, not getting into care, letting them know if they're even been treated or not, or even know if they're even HIV positive. So again, it says here on the right-hand side, viral suppression is defined as having a viral load in 2017 to be less than 200 copies. Being virally suppressed prevents transmission of HIV to others. I've already said that. 59% of people across diagnosed and living with HIV were virally suppressed. That is awesome. 60%. That means that there's still 40% of the people out there that still need treatment and care in North Carolina. And we talked about it earlier about how staggering the numbers is. Over 40,000 in North Carolina that are HIV positive that we're aware of. And just do the numbers there, somewhere in the ballpark of about, let's see, that's 18,000 still are not virally suppressed. We need to work and get those people in a healthier life. So barriers to care, achieving viral suppression include transportation, lack of family support, social stigma, the complexity of accessing health care insurance. How many knows about the health insurance and how that's going? The Affordable Care Act is not all it cracked up to be. As a person who's worked in helping our patients get insurance, some of the insurance that's out there is very affordable and cheap, but by the time a patient tries to get care and services, it covers almost nothing. So having insurance is not as good sometimes as not having insurance, believe it or not, from a perspective of a healthcare worker trying to help our patients get coverage. And the other thing is the Latino residents of North Carolina have a lower viral suppression than other racial ethnicities. And there's all kind of reasons why that may happen. Barriers are up everywhere, and we want to do what we can to reduce those barriers every single time we get a chance. So, safer sex options. If you told somebody, and for those of you that work in tobacco cessation, and you say, okay, the only way for you to get off of cigarettes is to quit cold turkey. Okay, I know some of the clocks are turning in your head and saying, well, that doesn't work for everybody. Exactly. It really doesn't work for everybody. So if you tell somebody that you have to quit cold turkey or it's not going to work for you, you're not going to get a good response, I'm sure. Or if you told somebody that it's either all or nothing with whatever you're doing, then what reality is it out there? Again, we're trying to reduce, in this presentation, we're trying to reduce the possibility of someone contracting HIV and make them still have a fairly normal, healthy lifestyle. And if their lifestyle involves sex, then we need to understand first, number one, what is sex? What is sex to them? We talked about that briefly as we started off earlier today. It's just, what is sex? What does it mean? How do they define that? One of our some famous person and said, I did not have sexual relations with that woman. His definition of sexual intercourse or sexual activity did not include, apparently did not include oral sex. So again, what are considered risky and not so risky sex practices? Talk with the individuals. Ask them, how do they define sex? What do they mean? What do they mean when they have sex? I remember 10, 15, almost 20 years ago, in our high schools and even middle schools, the practice of receptive anal sex for young women was getting on the rise, because that was not considered the same thing as having penile vaginal intercourse, because they were still being virgins, and so there would still be virgins and save themselves for that wonderful person, but at the same time they were still having sex, or they were performing oral sex on school buses or behind the gym or whatever, and then they won't consider that sex. But we're talking about HIV here. We're talking about ways that HIV can be transmitted. We need to understand how a person views that, and our own biases have to be set aside. And we just need to give them the facts if we're trying to help them and truly get down to the root of what they understand sex is. Then you can actually discuss, if you're doing this, this is what you need to do to be more safe in doing it. So then you can understand what is a risky and a not so risky sex practices. Are there some that are more likely to contract HIV and some that are less likely? That's some of the things we have to talk. And then what is considered a safer sex practice? What is that definition? What does it look like? And it does vary from person to person. We have to understand and have to be able to effectively communicate what safer sex means, not for you, but what it means for that individual that you're working with or you're talking to. What does it mean for them? How is it going to affect their lives? How does it affect their relationship with their significant other? And is there any alternatives to intercourse? Do we have an alternative? If we don't, why do we have to have intercourse? Is that the only thing that's on the table, or is there anything else? Then you talk about other things that you can do to please your partner, or maybe even please yourself. The use of mutual masturbation, the use of gloves, finger cots, or other type of barrier devices. We didn't talk about finger cots earlier, or gloves, but those are barrier devices. Latex, non-latex gloves can prevent the entrance of HIV, especially if someone has had some nail work done, or maybe works out about with their hands, and they got cuts and scrapes and bruises on their hands, or maybe they have some sort of dermatitis or some type of dry, chafed skin. That's all portals of entry, and we have to understand that even dry, cracked skin, and some of it can allow HIV to pass through. Our number one protection against infections and diseases is our skin, and if our skin is not intact, then we need to make sure that we cover that up. The same purpose that we have for putting Band-Aids on wounds. It's not just to keep the wound safe, but it's also to keep things from getting in or out. And what about the use of toys? I mean, is that another alternative to intercourse or sexual practice? Sure it is, as long as you're not using the toy between two individuals, or you're cleaning the toy. This is my toy. I get to use it myself, and I'll share with anybody. This is mine. What is yours? And how can you describe that and talk to the individual about that? How can you help them to be more safe and still enjoy the pleasures that they seek? And I can't say enough, condoms. Are they 100%? Absolutely not. But by far, they're one of the best barriers. And when I'm saying condoms here, I'm leaning more towards the male condoms versus the female condoms. If you're not seeing a female condom, it can be cumbersome to use, cumbersome to insert. Many people find it kind of weird, kind of freaky feeling, and they just don't like them, even more so than male condoms. And again, what about the pre-exposure prophylaxis? That's another safer sex option for individuals. And then again, since we're talking about this, we're talking about I used to call this a safer sex buffet. So if you give them people options, when you go to the buffet, you can choose what you want on that buffet, right? You pay the one price, and you can choose whatever you want. So it's always good to give people that you talk to options. We work in behavioral health at Robinson Healthcare as well. And you naturally, people are coming down from drugs, alcohol, and other medications or whatever, or other things that may be addicted to. They're coming off of those, and then you're starting to tell them, well, you're not getting your drugs, you're not getting your alcohol, you're not getting those things, and we're going to start taking privileges away from you. And naturally, those people are going to be mad and aggravated because they're coming down from something that was normal for them to something abnormal. So when you offer people things, give them choices, they're more likely to stick with them if they feel that they have made the decision themselves. It's always good to give the power back to the individual and give them the option to make choices on their own. Your job is to help them, to get them into a better state of health. And what can you do? Sometimes people don't want help. We understand that, but it's always good to know that they have somebody they can talk to, someone that they can trust, to give them solid advice. Don't use your personal feelings about this. Try to get the facts. Make sure you give the facts to the best of your ability, because what I found with working in the schools, working in the communities, especially working with teenagers, if they find one thing that you said is not true, and they found there's a flaw in what you said, many times, especially with young teenagers or young adults, everything you said is considered wrong, and they're going in the opposite direction. What I find is that when you give young people the information and then encourage them to find out more on their own or come back with more questions, they're more likely to follow those because they feel that they have a choice in this. When people start taking away your choices, you actually start taking away the ability for them to trust in what you're doing. That's a lot for each of us to talk about or ingest. I don't know if this is a time that anybody has any questions at this point. Do we want to pause just a moment?
I don't have any questions that's come through yet. So if you want to keep going, and then maybe we can take a break at about 9:45-ish. That works?
Sounds good.
Like
Sounds good. I just want to make sure that I didn't want to run through it and thinking I'm 90 miles ahead and everybody's 90 miles behind, and I'm just sitting here talking to myself. I want to make sure that we have the ability to answer the questions if they come up. All right. So now, when we talk about HIV, we're also talking about other conditions or diseases that are indicators of the risk factors that we may have for contracting HIV. And when we do that, we're talking about either STDs, sexually transmitted diseases, or STIs, sexually transmitted infections. Inevitably, they're the same. It's just that they've changed the naming, the labeling of it, but it's the same. If you can get any one of these infections here, then you have to understand that you're also put yourself at risk for contracting HIV, as long as that individual has HIV in their system. Chlamydia. It's an easily preventable condition, but unfortunately, some of the statistics said almost 60% of women in America have probably chlamydia and may not even realize they have it, up to 60%. That's a startling statistic there, but it's easily preventable. And when we talked about it earlier yesterday, talking about how high a rate of chlamydia and gonorrhea infections and syphilis infections are in Robeson County. And these are easily preventable by the use of a barrier device, a dental dam or condom. But we're finding that we're having more and more people that are having unprotected sex. That's pretty much what it's telling us. Maybe they used a condom and it broke, and that's possible. Then that goes to another thing with making sure that we teach people how to properly use condoms. I had a story one time from a sex educator that we were working with, and they were telling us about a story that the educator was describing to a group of young ladies how to put on a condom. And they used, the instructor used a banana to show how to put a condom on correctly onto the male penis, and made sure that all the participants understood, and then they talked to one of the participants a few months later and found out that she was pregnant. And so she went to talk to her, and she said, well, was this a planned pregnancy? She said, no, it's not a planned pregnancy. She said, well, can you tell me a little bit about what happened and how it happened? She says, well, I did exactly what you did. I put the condom on the banana, laid it on the dresser, and then we had sex. True story. So you need to make sure that you're clear in your directions and clear in your instructions on how-tos and the where-tos. And she took it literally. She said she took it literally. So anyway, gonorrhea, same thing with chlamydia. It's another sexually transmitted infection that is easily preventable by the use of a barrier device. Syphilis is another one of those that's pretty much, with the exception of if there's sores that are broken out. Syphilis does have early on in its first early stages, it does have sores that can break open, and they may be contagious. But for the most part, the condom helps to prevent majority of that. Non-gonorrheal urethritis, trichomoniasis, pelvic inflammatory disease, most of these can be prevented. Pelvic inflammatory disease is not necessarily a sexually transmitted disease, but if the infection gets bad enough, it can any of these chlamydia, gonorrhea can result in pelvic inflammatory disease. And for anybody all the clients that I've spoken with in the past that talked about pelvic inflammatory disease said it's extremely painful. By the time it gets to the point that it gets to pelvic inflammatory disease, it can cause scarring. It can cause adhesions, and as a matter of fact, it actually can cause persons to become sterile. So this can be very serious, folks. Untreated chlamydia, untreated gonorrhea can pass on to the child, passed on to the unborn infant, and can cause blindness, can cause death in the child. Untreated chlamydia and gonorrhea over time can cause sterility as well in both males and females. Here's the thing. An infection can be treated and cured at the very bottom of the page here, bottom of the screen, but the damage that the disease or infection causes may not be cured. It can be treated, but it may not be cured. But these are considered the ones that are treatable. So, all right. So here's some sexually transmitted infections that are treatable, but not necessarily curable. The human papillomavirus, we've got a lot of publicity in the last 10 years or so with the vaccine for HPV, both for males and females, particularly in our youth, young adults, and it greatly reduces the chance of someone contracting the HPV strains that are most likely to develop into cervical and other type of cancers. And it does not treat, cure, or prevent all HPV transmissions, but it can do many. Some of HPV can have the growths that look kind of like cauliflower in your genital areas. Not all of them have those, but you can have those. Many times those growths have to be removed surgically with acid, or have to be cut off or surgically removed otherwise, and then certain creams have to be used. But the thing about it is the HPV can come back, and the genital warts, or the growths of the genital warts, can come back as well. Herpes simplex virus, there's different forms of that. One of those that we're talking about today is the one that's typically your genital herpes. There are other types of herpes, or herpes variations. Fever blisters are types of herpes. It's just a different form, but it's equally painful, and these are preventable for the most part. If you are a person that has herpes or herpes simplex virus, it's very good to know that you have it, number one, and to get treatment for it, because it can reduce the chances of you transmitting it to someone else. It also reduces the chance of someone having breakouts as often, and there's daily medications that are fairly safe to take to prevent the outbreaks, or reduce the amount of outbreaks. Hepatitis B right now is not curable, but it is treatable. But it is it's fairly preventable, because we do have a hepatitis B vaccine that is available, especially to all healthcare workers are supposed to have it. And even if you don't have even if you're not a healthcare worker, hepatitis B vaccine is being offered, I believe, to infants and children, toddlers now. The regimen changed quite a few years back, and it's worth the time to take the series. The series usually takes about 6 months. Your first injection may be given today, the second injection in 30 days, and then the third injection 6 months later. And then occasionally you may have to have a booster after so many years, but they can draw a titer sample of your blood and then see how much immunity that you have built up. Again, the last one here is HIV. That's one that's not curable, but is treatable. And like any other of things, if you don't know you have it, then you can't get the treatment that you need. HIV in women, increasing number of women are getting infected with HIV, and new infections occurring especially among adolescent women and women over 45. As a matter of fact, for adolescent women, the number one way that adolescent women are contracting HIV is through heterosexual activity with a male. And many times that's a male that's usually over 20 with someone that's, say, adolescent. African American and Latino women are disproportionately affected with HIV. That means they're getting infected more so, and they are. We need to target the minority populations as they're being hardest hit. We talked about that yesterday in some of the statistics. The African American or Black American is hardest hit for HIV infections and transmissions, and that is very similarly in the Latino women as well. There are many more issues facing the HIV infected woman, and there's so much more to this than meets the eye, and we need to be aware and conscious that when we're talking with anybody, it's not if they are a woman that is of childbearing age and they're able to have children, facing the fact that they could pass that on to their unborn child is a major issue. We need to have those discussions with these individuals. I mean, if they're already positive, okay, that's fine, that's great. Let's see what we can do to keep you healthy. Let's see what we can do to keep your baby healthy, and make sure we have the discussion that say, look, you may be pregnant, or you may be consider getting pregnant. Did you know that you can get on medication, get on treatment, and then greatly reduce the chance of your child being born with HIV? Wouldn't that be a wonderful gift to give to your own child, is not having HIV? That is awesome to know that we have those options, and we can pass that information on and get those individuals connected. Excuse me. What about women who have sex with women? Is there risk in there? What kind of risk is involved with a woman who has sex with other women? Yes, there is. We're thinking that, if you're a male who has sex with men, you're at the highest risk, and if you're a woman who has sex with another woman, you're at the lowest risk. That may be true, but again, there is risk there. Again, we're talking about exchanging of bodily fluids. So if HIV is present in one individual and that those bodily fluids get inside the other individual, then guess what? And it has HIV in high enough concentration, then it can be passed on. Back in 2014, there was an article that came out as a rare case that HIV-infected female infected their partner. It doesn't happen very often that we know of, but it is something that we need to be aware of. And just because it's a low risk doesn't mean there's no risk. All right, another thing. What if we're talking about HIV prevention through drug use? There are individuals out there that obviously are using drugs, and drugs have all different type of effects on the body. One of the effects is that it lowers our inhibition. But not only does it lower our inhibitions and makes us more susceptible to wanting to do things that we wouldn't normally do. And we're talking about drugs. We're also talking about alcohol, which is another drug. Alcohol and other drugs. We're also talking that it suppresses our immune response. And while it suppresses our immune response, then we need to know that then if HIV gets inside of our body, then it allows HIV to be contracted much easier, and also causes us to be able to allow the virus to multiply faster. So we need to make sure that we are aware. And so if we have somebody that is using injecting drugs, we can give them some training or techniques or tips if they're not going to stop. Again, we have to understand this is HIV prevention. This is not anti-drug campaigns. We're not promoting drugs. We're not promoting the use of drugs. But for those that are not ready to stop, what can we do to help them decrease their risk for HIV transmission? Please be clear on this. I've worked with many groups, the HIV and AIDS-related work with drug and alcohol addiction. And again, I want to make sure that I'm clear that we're not promoting drug use. We're not promoting the use of drugs in any way, shape, or form. But we are being realistic in saying that if you do use drugs, how can you use them safer until you're ready to quit or until you're ready to stop? Number one, if you're going to use drugs, if you're going to use needles, don't share the needles. I mean, and once I get high, I probably don't care. Once I get high, I probably don't care if somebody's using the needle, somebody's not using the needle. Once I'm high and I'm coming down and I want to get high again, if I see the needle, I'm probably going to grab it and use it anyway. All we can do is give them information. The other thing is if they're going to use the needles and somebody's going to use it between them, maybe we can teach people how to bleach the needles and wash them between the use. That is an option. It can be taught, and it is a process. It doesn't take very long to do. But again, if you're high, how many of you are going to actually think clearly about, oh, I've got to bleach this before I use this, or I've got to bleach this before I give it to the next person? That's probably not going to happen. But in the event, we're trying to do everything we can to prevent the exchange of HIV and other things like hepatitis B or hepatitis C. We need to at least give them the information. At least they'll have it. Another thing is a needle exchange program. For many, many years, we didn't have any needle exchange funding And as far as I know, there's not very many of them that are out there that has needle exchange funding. But we have had needle exchange programs in North Carolina scattered throughout. And needle exchange is simple, that if you have a used or dirty needle, you bring in your dirty needle and the program gives you a clean needle. Again, not promoting drug use, but promoting HIV, the prevention of HIV transmission. And then again, the last one here on the page is alternate drug use, non-needle drugs. So you want to get high. Have you considered not using needles and getting high using another method? Using smoking it or snorting it or popping a pill or something like that. I know it's not the same high, but it allows you to get high, and it greatly reduces your risk of getting a blood-borne pathogen or HIV transmission. And again, so you might want to have those discussions with them. If they're not ready to quit, you may want to change your path of thinking, and once they begin to trust you, maybe they'll consider quitting. I don't know. All right, so what about the prevention for HIV? Well, we talked about it really briefly yesterday, is that if we are HIV positive and we're the woman and we're pregnant or postpartum, we don't want to breastfeed. When a woman breastfeeds, not only is the milk could contain HIV, but also the process of the breastfeeding, the blood that could be ingested when the nipples and areolas become chafed, and the blood can come through the skin and be ingested by the infant. So if the infant was born with no HIV in the system, and they could get it through the breastfeeding process. So we've done all that work to keep the baby HIV negative, and then we breastfeed and we put that child at risk. Next one is mother to child. Again, have all pregnant women tested for HIV, and if HIV infected, the mother is HIV infected, have the pregnant mother on HIV medication, reduce the chance of child being born with HIV. And of course, they'll treat the child, and the child will be tested for at least 2 years to make sure that they did not seroconvert in that 2 years, and they'll treat the child throughout that. And typically after the second year, and they continue to test negative after the second year, typically the child is considered HIV negative. And we haven't had any problems with that. And we've actually had some women that were HIV positive, were not consistent with their HIV care, and had babies, and they were still HIV negative. It's just a phenomenon that I don't completely understand, but we do know that with treatment, with care, we greatly reduce the risk of that baby being born without HIV, which is great. Another thing is, don't donate blood products to organs or tissues, because that can be passed on. I do know that there's a good screening process that the medical professionals have with testing blood and blood products, organs and tissues. But if you know you're HIV positive, we just say, just don't do it. We know you want to help someone else, but that may not be the best option. I do know that there has been some controversy in the news in the last few years about people who are HIV positive donating their organs to somebody who else is HIV positive. Don't know how that's turned out, but a lot of the legislature is changing, and with the legislature changing and the laws that are changing, we're finding that the accidental exposure from one individual to another is not considered a felony crime like it used to be, not like a murder sentence or death sentence. So the face of law and legal views on HIV and HIV transmission has been changing the last few years, and the stigma is hopefully starting to not be as negative as it has been in the past. What is your message? What kind of message are you giving out? What messages are you sending to? Are they effective messages? Are the messages that we're giving to individuals in the communities, are they enough to stir them to action? When was the last time you were stirred to action? Somebody had a cause and it really moved you enough that I want to be part of this. I want to be part of this movement. I want to be part of this change. I want to be part of whatever it is that these people are part of. And was it your emotions that were affected? Was there a part of your life or your family that was affected? Did somebody die? Did somebody live? What was it that made an impact on you, and what kind of impact will you make on someone else? So what is your message, and how does that impact others? We have social media, various forms of social media. It's out there. Are we using those as tools to help us get the right message across to others? Or is it just a site for gossip? Is it just a site for casual time? Can we not use this as a tool to get the right message out? This message here, How to Kill Our Time Last Night, has been used for quite a few years by the Cumberland County HIV/AIDS Task Force. And every time that the bulletin boards were put, the billboards, not bulletin boards, but billboards were put up in Cumberland County, testing went up 100%. It was a simple message, and it talked about HIV and AIDS and getting tested. You need to make sure that the message we have is effective. It catches someone's attention quick, fast, in a hurry. And is it effective enough to make somebody go to action? What kind of call to action are we having? Are we getting the message? Is the message that we're getting across being effective, or is it not? We need to review those and find out. Because if our message is not effective, then are we reaching the populations that we need to reach? Acute HIV infection. When is it the flu? Yes.
I'm sorry. I do have a couple questions that have come through.
Wonderful.
She is wanting to know if you have specific data on Black and Latina individuals who are HIV affected.
What kind of data about HIV and affected?
She just asked if you have specific data. I don't know if maybe the amount in North Carolina or county-wise, if you happen to have anything specific to those demographics.
Yeah, we've gone over some of those earlier in this presentation. But yes, the data is there. We have data that comes from the North Carolina Department of Health and Human Services, the Communicable Disease Division. They have Epi Profile. They have the annual data. They have the quarterly data. We have local data. We have data for the regions. It's broken down by regions. It's broken down by county. And yes, that data is available. That data is free for access, and we can get that to you, or we can help you get that. And further on that in the presentation, which is downloadable for each individual by handouts. It has some of the websites that I'm sharing with everybody. But yes, that data is readily available. I just need to know what specific data they're looking for.
Yeah, and it doesn't say. So the handouts, again, we will send them out after with the link to the help desk. And if that doesn't answer the questions that you may have, Lauren, you can reach back out to us and we can get with Al to get you the information that you need. And sure. Then I also, let's see, there was another question that came through about the bleaching needles. And they were wanting to know the cleaning solution for that process.
The bleaching, you said?
Mm-hmm. The question asked about the cleaning solution for the bleaching needles.
Okay. Yeah, bleaching is fairly straightforward. Is that what an individual would do is they take a bleach, and then they would draw it up into the syringe where it fills the syringe up, and then let it sit there for about a minute or so, and then they push the plunger and get that out of there. But then they need to rinse it cleanly with water for at least 2 or 3 flushes at the very minimum. There are handouts that can be accessed with needle bleaching. It's not something that's very new. It's actually old, tried and true, that bleaching is pretty simple, that they use bleach. That's what they use. It's the cheapest, most effective way to kill HIV and many other blood-borne pathogens, as a matter of fact. It's not a special solution that you have to go and buy a special solution. Go get your regular old household bleach. That's what we're talking about using. But to make sure that it's rinsed completely, because that bleach, what's left in there, can burn and actually can kill if it's injected and not cleaned out properly. Usually the bleaching rinsing out is 2 or 3 different syringe fulls of clean, clear water. Preferably if you have distilled water, but if you don't have distilled water, you use what you have available.
Okay, I believe that answered that question, and that all that I have had come through. So I don't know, are you at a good stopping point where you need to take a
Yes, ma'am. Yes, ma'am.
Okay.
Absolutely.
So let's start back, I guess, at about, I don't know, a little after 9. Let's say 5 till. Does that sound good?
What time?
Let's see, what time? 9. Let's start back about 9:53.
9:53. Okay.
Yeah, let's say about 3-minute break.
Sounds great.
Thanks, Sal. Al, I think we're good to start back whenever you're ready. Al, feel free to go ahead and start whenever you're ready. I think we should be good to go to start back.
All right. Sounds good. Sounds good. Hope everybody's still with me today. And again, I'm glad to have each and every one of you here. Looks like we have 100 participants. And let's move on. We got quite a bit more to go. And I want to make sure I give you plenty of information and hope to keep you hungry enough for it that you want more at the end. All right. So as we move forward, again, make sure the message is good, make sure the message is clear, make sure the message is effective. Ask for feedback. Like today or today or sometime, you're going to give me feedback. What did you like? What you didn't like? What would you like to see differently? What would you like better? Things like that. We like to hear that. It helps us to grow. All right, so acute infection. When is it the flu and when isn't it? So we talked about it earlier yesterday. We talked about usually 2 weeks after you get initially infected with HIV, then there's a flu-like symptoms that come on, so very severe flu-like symptoms. And then that's when we usually find out from the individual, did you have flu this past year, or when you just, and then what were you doing 2 or 3 weeks before that? And usually we can kind of narrow down when it might have happened and how it might have happened. So if something has happened, it's a great opportunity for risk reduction counseling, just in case it was just the flu. Also a time for medical intervention, and then important of the risk for HIV exposure. Sometimes we don't even know how long a person's been infected, and we just have to treat them. That's why we have our testing for the CD4 and viral loads to see where they are in their HIV stage of life, and we work from where they are right there. We can't go back and change that. Acute infections, 2 to 4 weeks after initial infection, we talked about, it reproduces exponentially. It's not a 1-in-1. You know, one makes 10, 20, or 30. I don't know how many, but it just makes more. And the body begins fighting the infection and it's a flu-like episode. A lot of times it's usually the extreme or worst case type of the flu. It's not something that just, oh, I've had it for 2 weeks. Some people, it lasts longer than that. And during the acute phase, it could take up to 3 months for someone to test positive for the virus. And that's with some of the older testing, some of the newer testing. It's usually going to test a little sooner than that. But again, it just depends on the type of test you get and whether it's a venous stick, meaning you're getting blood from the arm and the needle, or you're getting it from the finger stick, or you're doing an oral testing. So there's clinical latency, asymptomatic HIV. It means it's been in the system for many, many years. If you remember that graph that we had earlier, at the first 2 to 3 weeks, it's really intense. It replicates quickly, and then it drops down, and then it begins doing damage to the body. But it takes years for it to actually do enough damage. Sometimes, especially if a person has a really healthy immune system, it may try to fight it off for years before it actually shows any type of symptoms. Therefore, the word asymptomatic HIV. It's not showing on the outside that you actually are HIV positive. It can take up to 8 or plus more years for it to show in the system, and depending on the individual's immune system, it could be more or less years. AIDS, the condition of AIDS. A person's immune system, again, has dropped. The helper T cells has dropped below 200 cells per cubic millimeter. During this phase, people begin to show outward signs of a weakened immune system. Through outward manifestations of the opportune infection, you'll start seeing this, diseases like Kaposi sarcoma, which is a cancer that our body naturally fights off. Purplish splotches on the hands, starts off on the hands and the feet, on the bottom of the feet and the pads of the hands, but it could actually go all over. I've seen pictures of people that have had late stage of Kaposi sarcoma where there's big boils coming out on their skin, and by that time, there's nothing you can do to reverse it. The PCP pneumonias and pneumonia that affects people that are HIV positive and their immune system is weakened. You don't have to be HIV positive to get a Kaposi sarcoma. You can get it from a very weakened immune system, and we want to make sure that that person is given the right antibiotics and the right treatment care, hopefully get them back to a greater state of health. I will tell you this, once a person's immune system drops below 200, it may take a while of intense treatment and therapy for that immune system to get back up to a healthy state. It's better to keep it healthy than it is to get it back to a state of health. Infections, number 3 down here, it says those infections that would normally be absent in a person whose immune system is well above the threshold are now present. that's where the AIDS condition kicks in. How it affects a person: causes fatigue, depression, chronic pain in some people. It causes nausea, diarrhea, fever, and night sweats. We're talking the night sweats that soak the sheets. I'm talking major sweating in the middle of the night. Delirium, dementia, weight loss, usually greater than 10 pounds, unexplained. And if you look at these, you'll notice that there are quite a few of these that we may already have and never thought about, because HIV, it mimics other diseases. So there's no real way to know if you have HIV or not without actually being tested. One of the test questions I'm asked is, how do you know when a person has HIV? You don't necessarily know by just looking at it. The outward manifestations may or may not tell you that they're HIV positive. The dialogue and then, of course, being tested is really the factor that makes that confirms if their person is having these. Most of us have probably had nausea at some point in time, probably have had diarrhea at some time, probably have had a fever, probably have had night sweats. Some of us may actually have chronic pain right now. Some of us may have fatigue, but it does not mean that we have HIV. But it does mean that if we haven't ever been tested, we do need to get tested, just so we'll know and we can move forward and get that out of our way. So if a person's not infected, great. If they are infected, what can we do to get them into care? That's important. How does it affect a person? Lipodystrophy. That means the fat will be moving to different parts of the body that it didn't normally move. People have buffalo humps, meaning that they have back behind the neck, between the shoulders, the fat will start depositing itself there. And of course, it'll always be in the lower abdomen region, but it'll be even greater. Hypercholesterolemia, that means your cholesterol will increase. And of course, when you get on HIV antiretroviral medications, this can be increased because the medications can cause your cholesterol be even higher. So that's another reason why we're going to do HIV testing, that we actually, a person that's positive will also get cholesterol testing and may have to be put on cholesterol medication as well. It's just an unfortunate side effect of some of the medications and the condition. PCP pneumonia, we talked about, Kaposi sarcoma, cytomegalovirus. A lot of times it'll affect your vision, and it's more present, especially if your CD4 continues to drop below 200 and even gets lower than that. And you'll have more cases of candida, yeast infections, and not just in the vaginal area, but also in the mouth. They'll start having the white patches and have to be treated for that more frequently and more regularly, and depending on the individual. Other things, it affects a person's in the social. When somebody else finds that they're HIV positive, it has been for many, many years. It's still not an accepted disease process. It's that people that did those things, negative view of HIV is still out there. It can definitely affect them medically, psychologically, mentally, emotionally. I know in Robeson County, some of the problems that we've had to deal with over the years with patients is that they still haven't told their family members for fear of rejection, being ostracized, or even rejected from their families. And so they don't have anybody they can confide in, and we become their confidants as medical professionals. So we become more than just a medical professional. We become the person that they can trust or they can rely on. So that's a different type of bond that you end up getting. Physiological, of course, and of course it is extremely expensive to keep this care up. So it's important that if a person is HIV positive, that they have access to places that can actually help them get the care and treatment that they need, and can help, especially if there's Ryan White funds to help them. All right, so HIV awareness. All individuals, regardless, should be routinely tested for HIV, just like getting tested for high blood pressure, diabetes, or high cholesterol. If you fit any of these situations, you should be tested. If you engage in any sexual activity, willingly or unwillingly, even once, then you probably need to be tested. Sharing needles, whether illegal drugs or legal drugs. It doesn't have to be an illegal drug for you to get HIV transmitted to your body. So you need have been exposed to someone else's blood or body fluids ever in your life, then probably need to be tested at least once. We have had individuals that I have done the post-test counseling, know that they were positive, and I gave the test results out. And they were completely oblivious to the fact that they could have even been at risk. Well, I've never done anything that would put myself at risk. I've been married all these years. I didn't know he or she was even HIV positive. I didn't know where I got it from. And then I found out from you that I'm HIV positive. How could this have happened? Again, people don't even know what's going on around them sometimes, don't realize that maybe there's an unfaithful partner, or maybe they were exposed at work and didn't realize that they were positive. Lots of options there. Everybody should be tested at least one time, and we recommend anybody 13 to 70. And if they're at risk at younger ages, what if it's a child that's been molested, or a child that's been raped, or worse? We don't know. They still need to be tested so they can get treatment and care for all type of things, not just HIV, but mentally, emotionally, physically. And don't think the senior adults are out there, those that are over 70 are not sexually active, but folks, they are. That's a pause. There was an intentional pause. Folks, they are. Ever since the advent of erectile dysfunction drugs that have come out, we've had stories of people, the men who would get their checks, and they would have women to come in and pay them for sex from outside of the facility, the retirement home or the nursing home, and then turn around and have sexual activity with people that lived in the nursing home, their girlfriends or whatever else. So yes, it is happening, folks. And so we are also having an aging HIV positive population, meaning they've been positive for years and now they're getting older. And those individuals are still sexually active. So for those of you that think that grandma and grandpa only had sex for as many times as many children they had, some of them are still pretty sexually active. So we don't have to assume that they are or they're not. Everybody should be tested at least once. What's the pros of getting tested? You can take advantage of early treatment and care. You know whether or not you can infect others. You can increase the commitment to good health habits, can decrease anxiety, and, of course, prevent transmission to the baby. Other testing, things like the cons, it can increase anxiety and increase depression if you're positive. It can, the risk of job insurance discrimination. Unfortunately, there's some out there that insurances are kind of iffy about covering those. That you had the pre-exposure, condition that was that you've had before, and they may or may not do it. And of course, you're higher risk because it's going to cost more for that insurance company to keep you covered, and so your rates are going to be higher a lot of times when they find things like that out. Rapid testing is great because you can do it in 20 minutes or less. Some of the tests are as little as 10 minutes or less, and you can find out the viability of these 20-minute tests. Right now, there is a finger stick test that's out and has been out for quite a few years that not only tests for the antibody, but also tests for the antigen. The antigen equals HIV. It actually looks for HIV, not just the antibody that the body produces, meaning that they can get you a finger stick test in 20 minutes to find out if you're HIV positive and that you may have been exposed in less than 18 days or less. It's possible. So they're out there. They're out there. And it's not hard to get tested. There's a website that you can go to. I think it's hivtest.org, and you can put in your zip code, and it'll show you the places that are offering testing, not only just HIV, but also other types of HIV and STD testing in the areas that you live in. It's a wonderful, wonderful tool to give to someone else in case they don't want to get tested where you are, but they want to go. Many people will go out of county or go out of state to get tested because they don't want the local people to know that they're HIV positive. It does happen. So there's our pros and cons of rapid testing. There's pros and cons of traditional testing. I remember when I got one of my first HIV tests back almost 30 years ago, it took 2 weeks to get the test back. 2 weeks. Can you imagine wondering what it was like to get a test back, waiting 2 weeks to get a test back? Now we can get it in 20 minutes. Robinson Healthcare is one organization, one agency out of many across the state that offers HIV rapid testing. We have some agencies that we don't do directly, but some agencies that will go out to the bars, go out to the clubs at 2 o'clock in the morning and test right out there. Those are people that we ought to stand and applaud, because they're getting to those individuals that are putting themselves at greater risk than those that are coming into the health centers. That's wonderful to know that there are people out there that are advocates for getting people tested, and I applaud them and stand behind them 100%. Awesome job for those. Targeted groups, this says ages 13 to 64. Look, if you come in and you're 90 and you want to get tested, we're going to test you. We've had people that were older than 64, older than 70, that we tested them for everything else and we missed it. And they went to the hospital, and one of the hospitalists says, we've tried everything else. Let's just try HIV test just for kicks. They tried the HIV test. Sure enough, professionals that have been doing it for all this time still missed it. So we don't look at the age, even though that's the recommendation from the CDC, 13 to 64, 13 to 70. If you think you've been at risk, then we're going to get you tested. It doesn't cost us any more to do that or any less to do that. It's covered. Most of the time that you have testing in North Carolina, if they're on with the North Carolina Department of Health and Human Services, most of that testing a lot of times will be it, or might even actually be free. Sometimes it's not, but many times the rapid testing program in North Carolina is typically free. And some of those the website that I told you a while ago, HIVtesting.org, a lot of times that will tell you if it's free testing or not. Positive test results means that you do have HIV. You can infect others. Does not mean you get AIDS, but it does not mean that you're immune to AIDS either. But it does not mean, and antibodies does not mean that you have resistance to HIV or the AIDS condition. It just means that you have antibodies built up in your system that are trying to fight HIV. Negative test does not mean that HIV was found in your body at this time. It means that HIV was not found in your body at this time. It does not mean that you're not infected. It doesn't mean that you're immune to AIDS or that you have a resistance to infection. And it does not mean that you'll never get AIDS or get HIV. It just means at this time we can't find the infection in your body. Now, again, all the tests that are out there that are finger stick tests, they're looking for antibodies. There is one test that's out there that actually has an antibody and an antigen test, and there are differences in those. And this presentation doesn't have time to get into the details of that, but it's very we have 4th generation testing now that looks at the antigen to see if the antigen is. It's like having a viral load test. If you're positive, you need emotional support, medical care, and treatment programs. Who is Ryan White? Ryan White. This is important because this is a funding stream that helps those that are HIV positive. It was named after this young man right here. Ryan was one of the first children with hemophilia to be diagnosed with AIDS. He was his mom was courageously fought AIDS-related discrimination and helped educate the nation, not just the local area, but the nation about HIV and AIDS. He literally is the poster child for HIV because he did not fit the mold of the gay white male. That's who was getting infected. He was someone that got it through a blood transfusion. He was from Kokomo, Indiana, was attending Western Middle School, and he was diagnosed with at age of 13. He and his mother, Jean White Gender, who is still fighting the fight. He died at age of 18, only 5 years in this. But in April of 1990, just a month before Congress passed the AIDS bill, that it's now called the Ryan White CARE Act, and CARE stands for Comprehensive AIDS Resource Emergency Act. And we have some funding here at Robinson Healthcare, and if you want to know more about where those funding sites are, if you'll type in HRSA, that's the Health Resources Service Administration, and then type in the HIV/AIDS Bureau, and then type in Ryan White grant sites or whatever, and then you can find out where those sites are all across the United States and throughout the U.S. territories as well. And if you can't find it, if you'll contact me, I'll help you find it so you can help someone else. Legislation has been reauthorized in 96, 2000, 2006, 2009, 2013, and now it's called the Ryan White HIV/AIDS Program. There's most of the funds are primarily for medical care and support services, but there's equal critical portions for technical assistance, clinical training, and research, innovation, model care, It looks at how we can keep the people doing the jobs that they can do best they possibly can to. We get the people trained, and we get the services for patients. There's a Part A, B, C, and D. A is typically your metropolitan areas. Before 2006, North Carolina did not qualify for Part A funds, but now we have Charlotte has some of those funds. It's one of the largest blocks of funding that HIV is given out is in Part A. Part B is given to the state, and the state gives those out. That money covers the HIV medications, and for someone that gets treatment and care, you go get your prescription. You go to the pharmacist, and the pharmacist says, "Hey, I need you to pay for this. It's going to be $3,000. How are you going to pay for that? I don't know about you, but I don't have an extra $3,000 a month to cover this." Part C is comprehensive care. Part D is family-centered care. Robinson Healthcare has Part C and Part D, and then we work with the Part Bs and Part As in the state to deliver the best possible care and cover all the areas. There is a Part F, and you can see that and you can get more information about that. And let's see, go on. What are some of the things that you get with Ron White Part C? Primary care, you get from A to Z, lab, x-rays, diagnostic tests, medical, dental equipment, supplies as needed, case management, medical records, access, patient education, transportation. Yeah, transportation, folks. Yes, that's wonderful. We get transportation, helping people get back and forth to their appointments if possible. Clinical and diagnostic services. Other thing, HIV counseling, testing, AIDS drug assistance program. Now it's called the HIV drug assistance program. Health insurance payments if we need to. You're going to get covered. You're going to get care. Ron White Part C, that gives access for the patient's transportation, staff travel between sites so they can get back and forth and cover those expenses, translation services, educational materials, statewide coordinated statement of need. We're working with the state in the process to figure out how we can prioritize what the needs are for those that are living with HIV. Of course, patient advocates. We currently have over 250 patients in Robeson and Scotland counties that we serve just with Robeson Healthcare. There's one that's C.W. Williams is a Part D recipient in this Charlotte area that goes along with their Part A, and there's Newton Grove has Commonwealth Health, and then there's others. There's Florence, South Carolina has Hope Health, and we work with all those. Then we have Robeson County Health Department that has Part B services. And then we have Strahick and Fayetteville that has Part B services. And we all work together as a team to see if we can make the most effective. This is by far a competition. It's not a competition. It's anything but a competition. We're all working together to get people the best possible care they can get. So this will help you get people to where they can get assistance, to get care. This is what we can do. And this is information that you can give out to others. ADAP, PDAP, 340B pharmacy pricing, HIV diagnostic and care. These are things. And these are the addresses here on where some of the services are happening in our areas. We do partner with Scotland County Health Department, and they do HIV services on our behalf, and we've contracted with them. And then, of course, we have other things that we can do. Getting tested is important. I'm going through these very fast because our time is slowly coming to an end. We have about 12 minutes, and I want to give you time to ask questions. We've already had that slide. Different resources. We have Border Belt AIDS Resource Team in Robeson County called BART. And we have the Health Department. We have case managers in areas, lots of different teams to help in the fight against HIV and AIDS. Where are your resources? Where are these people? Robeson County Health Department, the Robeson Healthcare Corporation, Southeastern Regional Medical Center. They have an ID care provider staff. We also have Acme Medical in Lumberton, and they have a husband and wife team that are both MD providers. He's a gastroenterologist. She's an infectious disease specialist. They do wonderful things for our clients, especially those that are co-infected with HIV and hepatitis C. And we didn't even get a chance to get into the other stuff that day. But as far as HIV, you've gotten a bulk of what's going on. This information is here for you. Here's some of the resources we talked about earlier. These are for you to use, to share in any way you want, to get you started, to help you get what that individual may need and get you access. Tuberculosis is a big thing. For those that are HIV positive, it puts a person at more risk for getting tuberculosis if they're HIV positive. Same thing with hepatitis. You've seen a lot of work on TV with hepatitis C. and there is a cure for hepatitis C now. There is a cure for hepatitis C, but the person, of course, needs to know that they're hepatitis C positive. And of course, it does complicate things if you're hepatitis C positive and you're HIV positive. Lots more things, but let's get down to the last part of it. Universal precautions: treat all blood and body fluids as if they could contain HIV or hepatitis B or other bloodborne pathogens. Universal or standard precautions, as defined by the CDC, are a set of precautions designed to prevent transmission of human immunodeficiency virus, hepatitis B virus, and other bloodborne pathogens when providing first aid and health care. Under universal precautions, blood and certain body fluids of all patients are considered potentially infectious for HIV, hepatitis B, and other bloodborne pathogens. Remember, treat all blood and body fluids as if they could contain an infection that we don't want. Regardless of who they are, what they look like, it doesn't matter. Always use gloves. Clean up spills immediately. Use something to pick up sharp objects. Don't use your hands because the gloves won't protect you. Avoid splashing and splatter of blood or bodily fluids. You don't use makeup, lip balm, contact lenses, or eat where these things are present. Use soap and water. If you can't have soap and water, then use a hand sanitizer that has at least 62% alcohol content, or it's not going to clean it. And of course, get informed. Simply put, remember this, if nothing else: if it's warm, if it's wet, and if it's not yours, leave it alone. If it comes out of somebody else's body and it's not yours, use a glove, use protective, use a face shield, use eye goggles, use an eye mask, use something to keep that blood and body fluid from getting inside. Your eyes are portals of entry. Your nose is a portal of entry. Your mouth, your broken skin is a portal of entry. We want to keep you safe as healthcare professionals, and this is the basis for universal precautions or standard precautions when dealing with blood and bodily fluids. And that is a quick rendition of the presentation as we end it today. Amanda, back to you.
I haven't had any other questions come through, so I will go through our finishing housekeeping items. And if you do have a question that comes up, just type it in the chat box and we can ask Al before he leaves us today. Just to remind you that you will receive an email with a link to the help desk, which will provide all of the documents and the handouts that he was referring to, and that will include the resources on those demographics and the data that we had some questions about. It will also include a survey that we ask that you complete, and that way we can get those results in. And a reminder that certificates will be sent out as soon as we are able. Again, we do have some people that are out this week due to sickness, so we will get them out very soon. But that is really it that we have. I don't see any other questions coming through. So, Al, we appreciate it. We appreciate everyone participating in the webinar today, but that's all we have.
Fantastic. Thank you. Y'all have a fantastic day.
Thank you. You too. I'll stay on a little bit longer just to see if there are any following questions that come through.
Sounds good.
All right, Al, I'm going to go ahead and shut this down. If there's anything else that you need from Jamie or myself, just send us an email or give us a call, okay?
Same here. Let me know if you need anything. Thank you so much,
right.
Amanda. I appreciate it.
Yeah, thank you. Bye-bye.